Recording started.
Welcome to the world of endocrinology, where we will review tumor markers, hypothalamus, pituitary, adrenal glands, thyroid gland, reproductive hormones, parathyroid hormone, and bone. Tumor markers. It's important to make note of the fact that tumor markers are there to monitor therapy and disease recurrence, not to diagnose the patient as having a disease. The tumor markers of importance include alpha-fetoprotein, which is found in hepatocellular cancer and testicular cancer, also just found in the fetal liver. CA125 is an ovarian tumor. CEA, colon cancer, or an oncofetal antigen. I heard some students studying for this, and they said when enters anus, so they memorized it that way. HCG is found in pregnancy and testicular cancer. PSA is for prostate cancer, and it's also for screening. So this is a very important one that's used to screen, stage, and monitor, where the other ones are just used to monitor for recurrence. CA199 is colorectal, 2729. CA242 is colorectal, CA153 is breast. Moving on to the hypothalamus and pituitary, you have to be familiar with each of these hormones and where they come from. From the hypothalamus, we have releasing hormone, which stimulates TSH and prolactin. Gonadotropin releasing hormone releases LH and FSH. Corticotropin releasing hormone releases ACTH, and growth hormone releases growth hormone. Those ones are relatively easy because they do just what they say. A couple other things of importance are somatostatin, which stops growth hormone and TSH. You don't need those to keep going and going and going. Prolactin release. So those are a couple other ones from the hypothalamus. Then we've got anterior and posterior pituitary hormones. Anterior pituitary hormones include luteinizing hormone, which is involved in testosterone production. Follicle-stimulating hormone is involved in folliculogenesis and spermatogenesis, in other words, the making of an egg and sperm. Thyroid-stimulating hormone directs the thyroid hormone. Adrenocorticotropic hormone regulates adrenal steroids. Growth hormone affects metabolism and stimulates the liver to make growth hormone. And prolactin, which is involved in lactation. Posterior pituitary hormone. Oxytocin has a major role in labor and parturition, and somewhat in lactation. Vasopressin, or antidiuretic hormone, those regulate water balance. So a type of antidiuretic hormone can be in diabetes insipidus, where there's intense thirst and polydipsia, or deficiency of it. At the adrenal function next. The adrenal gland, as you can see here, is sitting up on top of the kidney. He just sits up there all nice and happy. He responds to blood pressure. So if you have that rises, let's start at the bottom. If you have blood pressure that falls, your kidneys are going to make note of that. So your kidneys are going to notice, okay, now I need to secrete renin. Renin will then cause angiotensinogen to go to angiotensin 1, and in the presence of angiotensin converting enzyme, go to angiotensin 2. This will in turn promote a small rise in blood pressure, but it can also cause the adrenal aldosterone, which then tells the kidney to retain salt, which will then increase the blood pressure. This is a small piece of what the adrenal gland does. You do need to know the difference between Cushing's and Addison's. This is a great chart that will help you make those distinctions. Somebody who's got hyperaldosteronism, primary or secondary hyperaldosteronism, just as it sounds, will have a high aldosterone. The only difference is Conn's has a low renin, and secondary hyperaldosteronism has a high renin. Then we have Cushing syndrome and adrenal insufficiency or Addison's disease. Cushing's always has a high cortisol, and Addison's has a low cortisol. Reviewing these one more time, if you have an adrenal insufficiency, it means you've got the major cause of this is having an adrenal corticotropic hormone deficiency. Addison's disease also has a low cortisol, weakness, and possible hypoglycemia. Cushing's disease refers to a high cortisol level over time, so they get that puffy face. Conn's disease is primary hyperaldosteronism, where you have high levels of aldosterone. When we refer to the middle of the adrenal, that's where we find epinephrine and adrenaline, which gives you that fight or flight response. If you have a growth of a pheochromocytoma, you can have increased amounts of these hormones from this gland, increase what we call catecholamines. What happens with people that have a pheochromocytoma is they have a feeling of panic attacks and having that fight or flight response like all the time. So there we'd have to go in and remove the pheochromocytoma and correct that. So when we talk about the catecholamines, we're referring to metanephrines, epinephrine, things like that. Usually we can do a urine test to see if there's too many of those. Moving on to the thyroid. The thyroid produces two hormones, thyroid hormone and calcitonin. So here's a picture of the thyroid itself. We have a thyroid cell. In the plasma, we have iodine. So we have that, which then is absolutely necessary to make thyroid hormone. From there, it goes in the thyroid, where in the thyroid, it is added to tyrosine, and it becomes, in the presence of iodine, monoiodotyrosine. From there, thyroglobulin carries it happily through the cell, where it becomes triiodotyrosine, and then it will be carried by way of a lysosome through and threonine, which has 3 little iodine pieces, and the T4, which has 4, which is known as thyroxine. We can have some disorders of the thyroid there. On the picture to the left here and the right here, we have the hypothalamus. He's way up on top. He sends thyrotropic releasing hormone to the anterior pituitary, which then sends TSH, which is in your neck. Your thyroid then makes thyroxine, which is used for tissues and things for energy. And depending on what the level of T4 and T3 is in your blood, it's able to tell your pituitary and your to either back off or make more TSH. So it's kind of a feedback loop of sorts. One of the disorders you can have is a hypothyroidism. If you have hypothyroidism or Hashimoto's disease, it's an autoimmune disorder where your immune system attacks your thyroid so it doesn't make very much T4 or T3. So what happens is the low levels of T4 cause your pituitary to keep more and more and more and more TSH. Well, it doesn't matter how much TSH your body makes, your thyroid can only make so much T4. So TSH keeps being secreted and secreted and secreted and secreted, but the thyroid just doesn't give. The pituitary starts to spit out even more TSH and more TSH, and the thyroid still doesn't give. So it's this constant loop of it trying to force it to make more T4, and it just. So those patients need to be put on thyroid therapy. Now, people with hyperthyroidism have what's called a thyrotoxicosis or Graves' disease. In this case, the thyroid has a mind of its own. It just keeps spitting out more and more and more and more T4. Therefore, your pituitary TSH, but it doesn't matter because the thyroid has a mind of its own. How they treat that is with radioactive iodine. So you saw in the picture before how iodine is taken up into the thyroid. If you make that radioactive, it will kill off the thyroid tissue and hopefully decrease some of that. TSH reference range is 0.5 to 5.0 milli-international units per liter. Now, the different thyroid hormones that are used are triiodothyronine, which is a T3, tetraiodothyronine, also called thyroxine, which is T4. We also have a couple proteins that carry these things around, thyroxine-binding globulin and thyroxine-binding prealbumin. The majority of testing done for these hormones is immunoassay. The majority of all hormones are done by immunoassay because there's such a small amount of them. Looking at the reproductive hormones, hypothalamus is growth hormone. Pituitary has the prolactin, FSH, and LH that we just talked about. Then we've got gonadal function. Testosterone is a major androgen that acts on the testes. It is involved from FSH. A couple different disorders you can have. If you've got Kallmann syndrome, you've got a decreased testosterone, decreased FSH, and decreased LH. Everything is low. In Klinefelter, you've got decreased testosterone and increased. With the ovaries, we have estrogen, which promotes breast, uterine, and vaginal development. Progesterone, which readies the uterus for implantation. FSH causes the production of egg, causes the spike or the release of an egg. And if you have too many androgens, it can cause hirsutism. Moving on to calcium homeostasis and hormonal regulation. Calcium is very important to keep at a normal level in the body for many reasons. It plays an important role in bone formation, muscle, and heart contraction. So if somebody's calcium levels start to go out of whack, they start having issues in those areas. The organs that are involved in calcium regulation include the intestine, the bone, and the kidney. In the gut, we need normal vitamin D and functioning intestines in order to be able to absorb it. In the bone, we're constantly breaking. So if you need more calcium for your muscles, your body will take it from your bones. Bone formation is by the osteoblast, and the breakdown is by the osteoclast. The kidney disease can embarrass calcium because the kidneys are able to excrete and reabsorb calcium as needed. So if you're dumping too much calcium out of your kidneys, you're not going to be able to retain it. Vitamin D is also important in the hormonal regulation. It's a hormone. So the most important effect of vitamin D is to facilitate the absorption of calcium from the small intestine. Along with parathyroid hormone, vitamin D also enhances the fluxes of calcium over the bone. Vitamin D synthesis begins with de novo synthesis in the skin. In the skin, cholesterol is converted to vitamin D3, and in the liver, the vitamin D3 is converted to hydroxyvitamin D. From there, in the kidney, hydroxyvitamin D is converted to 1,2,5-hydroxyvitamin D, which is your active form. Phosphorus is another element that is used. The renal excretion of phosphorus is by the parathyroid gland. You need phosphorus for bone growth. So it's important to make note of with phosphorus is that an increased parathyroid hormone will decrease phosphorus and increase calcium. So if you have a decreased phosphorus, you're probably going to have increased calcium. If you have phosphorus, you'll have a decreased calcium. So they're kind of inversely related there. Then we have parathyroid hormone. Parathyroids are found in your thyroid as well. It functions to stimulate bone resorption and release of calcium from the blood. To increase reabsorption of the renal calcium and promotes intestinal absorption of calcium. So very important on allowing calcium to come into the blood. If you have hyperparathyroidism, you will have an increased calcium but a decreased phosphorus, because remember, calcium and phosphorus are always opposite. If you have secondary hyperparathyroidism, you have an increased parathyroid hormone and phosphorus, but a decreased calcium. Calcitonin is another one produced. It is a hormone that functions to reduce blood calcium levels. One of the only ones that decreases it. It is secreted in response to hypercalcemia and it has two effects. One of them is it suppresses the tubular reabsorption of calcium. It's bone resorption, so your bones won't pull it back in. Important things to note about a calcium level. Do not use an EDTA oxalate or citrate tube because they bind up calcium. Instead, you should use a red towel or a lithium tube. A few notes on the bones, since we're talking about bones in this chapter. Rickets in children causes bony deformities. Osteomalacia is a softening of the bones in adults, but no deformity. Osteoporosis, which can be found on a bone scan, is like holes in the bone, kind of porous. They treat that with Boniva, increase of calcium, and vitamin D.